towards earlier recovery in an aging population.
Good afternoon, I am Jessica SCHEMBRI Higgins, a higher surgical trainee in general surgery, and I'm practicing in Mater Dei Hospital here in Malta. So I would like to invite all the panel members to join me here and to give a quick introduction and a little background about themselves, please.
Professor Hedi, Dean of Faculty of Medicine of Sousse and Head Department of Gynecology Obstetric in Sousse, Tunisia.
I'm Dr. SCICLUNA. I'm Senior Lecturer and Principal Investigator at the University of Malta. I'm specialized in experimental medicine and my interests lie in translational molecular medicine.
Alex ATTARD, until recently consultant surgeon, Mater Dei Hospital.
Dr. Josh at the CARO. I'm a senior lecturer at the University of Malta in the physiotherapy department, and currently we are leading research into physical activity in the retirement process.
Robert XUEREB, Chairman, Department of Cardiology, Mater Dei Hospital, immediate past President, Maltese Cardiac Society.
All right, so the United Nations and the WHO have actually declared 2021 to 2030 as the decade for active aging. And I believe this is very important. Why? Why do we need a special decade dedicated to our elderly patients? Because the elderly patient is complex. They come with their own set of comorbidities, with their own challenges with regards to diagnosis and management, and we as clinicians tend to have our own bias when dealing with such patients. So, starting off from your own personal experiences, what were the challenges? For example, Mr. ATTARD has been one of the pioneers in actually implementing minimally invasive surgery here in Malta. What were your challenges in trying to pioneer this new technology while making it safe for our older patients?
First of all, I'd like to start off by emphasizing that when I started off in surgery many years ago, the surgeon made all the decisions. So basically, it was a one-man show with elderly patients as it was with younger patients. Times have changed. Now there is a multidisciplinary approach to everything. It's what I call decisions by committee, but in any case, this is particularly important with the elderly population. So, as we all know, maybe some of you know, that ERAS has become the buzzword for the last few years, enhanced recovery after surgery. More recently, it's being applied to the elderly population, but prehabilitation is also another buzzword which applies to the elderly patient. So minimally invasive surgery is one of those things that have been identified as possibly enhancing recovery in an older patient, along with proper preoperative assessment for frailty and comorbidities, etc., etc. So I think it's been a combined approach which has possibly resulted in better results in this population.
Speaking of the combined approach, we have here Dr. CARO, who has actually given us a very good speech about improving patient mobility, improving patient rehabilitation. What have, from your past experience, so what have been the biggest challenges for you, especially in the context of very elderly and comorbid patients, and bringing them back to their baseline? And how can we as a team work together to make this happen?
So if I spoke from my point of view, I think that one of the biggest challenges we have is to adopt the person-centered approach and live it as we speak about it. So we need to understand the human person better so that we can then move forward in helping that person maximize their potential in whatever area it is. And that is the basis of the research that we are doing, actually. We are trying to understand how the persons interact, basically, what they think, what would motivate them, what things serve as barriers to them moving forward, and then trying to integrate that in any form and way that will promote a better lifestyle moving forward. With older persons in particular, we are all too aware that well-being for older adults is very closely linked to physical activity. And physical activity here, it's important to understand the definition that it is not exercise per se. So it's not about running or swimming or playing tennis, as we would understand exercise. But physical activity is engaging in movement that is necessary for quality of life. So it could be just walking, for example, something like that. So yeah, just to answer that question specifically, I think that the major hurdle we have is probably understanding the human person properly so that we have a better person-centered approach in advancing forward.
Thank you. So the WHO estimates that by the year 2050, actually the number of people older than 60 years old will go up from 12% to 22%, and that rounds up to 2.1 billion people. Dr. XUEREB, do you think we are equipped to deal with this aging population?
Okay, so it's nice to start off, Jessica, with where we started from. So only 30 years ago, when I returned from my training in cardiology, the cutoff point for having a simple X-ray of the arteries of the heart, a coronary angiogram, was 40 years. If you were above 40 years, you were not entitled to have a coronary angiogram. Where are we now? Only yesterday I received a WhatsApp from a neighbor of mine. This neighbor of mine, 7 years ago, came to me at the age of 93 years. She had just been admitted with heart failure. So she was admitted to the emergency department really short of breath. And she was told she's got a very narrow valve. The aortic valve was very narrow, the valve between the heart and the main artery of the body. And she was told, well, there's nothing to do. Well, she researched it and she came up to me and told me, I want to have a TAVI. TAVI means changing the valve from the groin. So I told her, you're 93 years. You can end up with a stroke. You can end up with the need for a pacemaker. You may die while I'm doing the procedure for you. And her reply was, well, if you don't do the TAVI for me, I'm going to die. I want my TAVI. So 7 years ago, I went in half-heartedly to do this TAVI. Yesterday, I received a picture of her celebrating her 100-year birthday. And she told me, I told you I want to live to 100, and thanks to your TAVI, I'm alive and well. So this is where we are today. And the title of this session is Towards Early Recovery in an Aging Population. Well, we've also changed our practice in these interventions. So nowadays, we're changing the valves from the groin, doing them under local anesthesia. So an elderly patient would walk into the theater, we'll do the valve on him under local anesthesia, and observe him overnight and discharge him the following day. So this is the form of practice and innovations which happen in cardiology, the revolution which has happened in cardiology, which has allowed us to treat the aging population and also getting them to have an early recovery and return home to be physically active within a day.
So essentially we are scrapping away the ageist mentality and adopting a more patient-centered approach where we do not just look at the patient on the context of age alone, but at their functional status, at what they're able to do, such as this neighbor of yours. And I think this is at the very core of our discussion today. So the elderly patient is quite complex, not only because they come with many comorbidities, but also because they are a vulnerable group and they come with their own ethical dilemmas. How do you think we may be able to navigate our way around this, Dr. SCICLUNA?
Ethical dilemmas. Well, I'm no ethics expert, that's for sure. Though I reckon that the first thing is to enable proper monitoring of our senior population, be it post-surgery or after receiving some interventions. And here we're at the MedTech Expo with, we're seeing a lot of technological innovations in terms of AI, for example, another buzzword around. And it's important to, one, integrate all these sources of new technology to better monitor our senior population, and in particular, better monitor their functional state or functional status. We can definitely no longer think in terms of one bucket will fill everybody. So we have to start thinking in a more personalized way. And be it at outpatient clinics, but also in terms of identifying aging trajectories, where we would know that a particular trajectory may lead to, for example, exacerbated COPD. Another particular trajectory may predispose a person above 75 with CHF. So, in essence, I think the overarching answer to this is to enable technology to monitor people, and in particular their physiological status, be it using genomics or genetics, or even using what I've presented, immune functional assays. And this way we can at least target our elderly population in a more precise way.
Right? Yes, Mr. Attard.
I think we need to change our mindset. We have to go from considering biological age and forgetting about chronological age, which still is a problem. A couple of years ago, we had a patient, 101, the oldest patient I've operated on. She had a very large thyroid and couldn't swallow. And she was refused surgery on the basis of her age. But she didn't take even a simple aspirin a day. She was on no medication whatsoever. She had no alternative. We did her, and it was a successful outcome. It's biological age we need to think about. Also, I think the mindset change, especially with surgeons, is to involve those specialties which in my time were not considered important. So, for example, geriatrics. Geriatricians play an important role, especially if we are going to approach the patient from the ERAS perspective. Prehabilitation. Prehabilitation would include, say, physiotherapy before the operation to maintain mobility after operation, which has been shown to ensure a better outcome. These are things that, in my time, were never considered. Now they have become important because expectations are higher, and also because, as you said, the percentage of patients, elderly patients coming our way has increased.
Agreed. So, yes, Dr. SCICLUNA?
Yeah, I have to say that, Mr. Attard, you hit the nail on its head. I didn't have time to show this in my presentation, though the chronological age of an individual is being seen as not proportional to biological age. So there are various means that we can use epigenetics to estimate the biological age of various organs, for example, lungs, livers. And what has been observed numerous times is that the biological age of each tissue differs also within the same system, within the same individual. And they do not correlate with chronological age.
Exactly.
So I think this is a very, very important point.
It emphasizes the importance of the patient-centered approach rather than just taking age as a number.
And the biology within.
Prof. KHAIRI, I want to ask you a question. Dr. SCICLUNA mentioned the adaptation of research to our elderly patients. However, a common pitfall of most literature and clinical trials is that they exclude elderly patients. Most trials and research actually focuses on adults between 18 and 60 years of age. So how can we adapt that research to the older patients?
Please, about our vision in our Faculty of Medicine, I prepared just a short video with my assistant to show our vision about this subject.
Okay.
So
Can we have the video, please, then?
Thank you.
We envision a world where individuals are active participants in their own health, utilizing AI-driven tools and knowledge to make informed decisions that resonate with their unique needs, desire, and aspiration. This vision is not about replacing human touch with algorithm. It's about complementing our human capacity for care and understanding with the endless possibility of AI. To optimize healthy aging, we can define 3 crucial axes. The first axis is centered on prevention. This involves implementing comprehensive measures to control the risk of injury and effectively manage chronic condition or comorbidity. The second axis focuses on promoting the health and the healthcare system. This entails not only improving access to quality healthcare, but also ensuring that healthcare services are tailored to the unique needs of the aging population. The third axis recognizes that healthy aging requires more than just physical health. It necessitates a real and meaningful social engagement. In these days, we must be aware of the emergence of a paradigm shift as the scientific literature abounds with articles delineating a profound transformation in our understanding of medical knowledge. While evidence-based medicine has represented the emerging phase of the iceberg in our quest for medical knowledge, AI now promises to unlock a deeper, more extensive realm of understanding. Precision medicine, ensuring holistic view, is embraced to the multiple facets of health and aging using AI as a tool. For instance, deep phenotyping using AI offers a comprehensive molecular profile of an individual's physiological state, allowing us to longitudinally track pathways from health to disease transformation. By leveraging diverse omic technology and physiological measurement, we can molecularly characterize an individual's disease risk. Moreover, through the implementation of a system approach to big data analysis and integration, we can establish a robust platform for machine learning and AI, revolutionizing clinical decision-making for early disease risk identification and prevention. Another paradigm shift is emerging in the form of a novel diagnostic integration approach based on the concept of treatable traits. This approach seeks to identify clinically relevant therapeutic targets that can be easily pinpointed using a specific biomarker. Ultimately, personalized diagnosis for each patient, a concept known as personalized care. Here, artificial intelligence plays a pivotal role in leveraging big data to help identify new treatable traits, develop innovative biomarkers, and even explore potential treatments. The Internet of Things is a cutting-edge AI-driven technology with the potential to significantly enhance the management of conditions commonly associated with aging, such as dementia and disability. It offers an array of tools including wearable sensor for continuous monitoring and smart connected devices that enable seamless communication with healthcare facilities. Furthermore, these tools are continuously evolving, aiming to simplify their use, enhance efficacy, ensure safety, and ultimately reduce costs. So to be more large, AI-driven precision medicine can offer a shift from traditional one-size-fits-all medical approaches to tailored care plans that consider an individual's genetic, lifestyle, medical history, and current health status. The integration of AI with precision medicine enables the early detection of potential health risks in older adults. By identifying subtle changes at an early stage, we can intervene before disease progresses, enhancing the chances of successful intervention and maintaining quality of life. Our approach emphasizes evidence-based decision-making. AI technology assists healthcare providers in analyzing complex datasets, generating insight, and predicting health trajectories. This data-driven approach ensures that interventions are targeted, effective, and aligned with the specific needs of each patient. We envision a healthcare continuum where AI-powered tools facilitate seamless transition between different care settings, from clinics to telehealth consultation to home care. This continuity enhances patient outcome and fosters active aging by enabling older adults to receive consistent, comprehensive care.
Thank you for that. Going back to my previous question, because I think this is a very important point to make. We're at a conference where all day we've been hearing about innovation, about new technology, about research. But how do we apply this research, Dr. XUEREB, to our elderly population when most trials actually focus between 18 to 60-year-old patients?
Yes, that is true, but also many of the innovations that are going on are actually for the aging population. In other words, in cardiology at least, most of the research going on is in heart failure. Arrhythmias such as atrial fibrillation, which is the commonest arrhythmia, and in valvular heart disease, and we're no longer seeing rheumatic valvular disease. Now we're seeing degenerative valvular heart disease. So the innovations going on and the research going on is actually now looking into the elderly population, because we all understand that cardiology is becoming a specialty mainly dealing with elderly population, heart failure, atrial fibrillation, valvular heart disease, just to mention a few. And when coming up with these innovations, we are having new medicines which help reduce hospital stays and therefore improve the rehabilitation and improve outcomes for our elderly patients, which help patients be mobilized and decrease hospitalization time for interventions. So I think the industry is there, the cardiologists are there, the mind frame is right. We need to bring the politicians on board to prepare for, as you say, in the coming years, we are going to have a marked increase in our elderly, and therefore a marked increase in such cardiovascular diseases and other diseases of the elderly.
So essentially, as researchers, we have to broaden our horizons and our population groups, and perhaps even do subgroup analysis and further study these patient cohorts to be able to give more accurate data, more accurate projections on the latest topics, on the latest innovations and how they impact the elderly patients. To sum up, because we don't have a long time left together, so if you had to summarize in a couple of sentences, what is the most important take-home message that you want us to take with us home today, what would that be? Prof?
Just develop research and for courses in medical school, we must implement, we have to implement the age, quality of life, the age in our courses. And in my faculty, we have a department to think how to include the age person in our courses.
Thank you.
We are all unique. We have our own stories since birth and throughout our lives, and in particular during the aging process. And we all have our own aging trajectories, be it driven by lifestyle factors or interventions or vaccinations. And we should all embrace our heterogeneity, and we should leverage on the tools to better understand drivers of that heterogeneity. And in this way, we may be able to identify certain interventions or changes in our lifestyles that can benefit us, and in addition also identify things or interventions that can harm us in the meantime too.
Thank you. Mr. ATTARD.
From a surgical perspective, I think now that we've accepted the multidisciplinary approach for elderly patients, we need to involve geriatricians more and more. They know how these patients react to doses of medicines, etc., which are different from your younger population. And we have gone from my time where an elderly patient was denied an ITU bed just on the basis of age, the patient who would have needed it most. Nowadays, that is unacceptable. However, I think if we want to maintain good results, then we have to approach it in a different way.
Thank you. Dr. Sherry?
Thank you. From my perspective, for sure, medical technology is a great thing. Innovation and advancement is something amazing. It's something that we have to embrace, and we have to work with it and work with it well. But clearly, if we are going to adopt a person-centered approach, we must make sure that any advancements are sensitive to the persons, and therefore there's a value in collaborating between the fields of technology and human behavior to bring out the best products for our generations today and tomorrow.
Thank you.
So when it comes to cardiology, when we have a patient, age does not come into account. It's the patient in front of us that counts. You may have a 90-year-old who may be fit and go in for intervention, and the age does not come into account. But I think we have to focus also on prevention. We have to think on healthy lifestyles for our elderly. We have to encourage physical activity for both physical and mental well-being. We have to encourage healthy diets. We have to encourage regular checkups to maintain blood pressure control, diabetes control, cholesterol control, to prevent as much as possible further problems of coronary artery disease, strokes, and heart attacks. So prevention still comes to play even in our elderly.
I think that's a very good point, actually, because here you're not dealing with the problem when it occurs, but rather you're preempting the problem, at the same time reducing the burden on the healthcare services and also the burden on the patient. And in fact, the Minister for Health mentioned it in his opening speech, that prevention is better than cure. And it's a very, very important slogan that we take home with us today. I once heard a saying that stayed with me. It's not the years of life that count, but actually the life in our years. And I think it's not just about prolonging life and prolonging survivorship in our patients, but looking at what quality of life those patients have. What is their daily life? What's their quality of life? What are their activities of daily living? Are they passing each day sitting down, looking at television, or are they active members in our society? And I think it's very important to focus on the life in our years rather than the years of life. One last thought. How can we contribute as health providers to the life in their years rather than the other way around?
Rejuvenation.
Rejuvenation. So bringing them more in our society, treating them as less as a burden and more as an important contributor.
Absolutely.
Acknowledging that our elders have a very important role to play still in our society, that in their wisdom they're able to contribute and to teach us even at their age. Dr. XUEREB?
By encouraging them to remain active in whatever work they were in, active in contributing to our society, maybe in local councils and governments, active in physical activities such as gardening or working in fields, active in their family and in society.
Thank you very much. Thank you to all the speakers. This has been a very interesting session, and I wish you a beautiful afternoon. Thank you.